Early detection of colon cancer can save lives, but fewer than 60% of eligible Americans undergo screenings. It's hoped that a new blood test that can help identify colorectal cancer will improve those screening numbers. That test is awaiting FDA approval. Dr. Madhapa Kundranda, gastrointestinal medical oncologist at Banner MD Anderson Cancer Center, joins us now. Good to have you here, doctor. So we're talking, when this first came out,
right,
we talked a little bit about this because it just seems so revolutionary. A blood test for colorectal cancer, huh?
Right. So, no, thank you, Ted, for bringing awareness to this important issue, especially with the rising incidence of colon cancer, colorectal cancer in young adults. And as you indicated, 60%, although we have a test, the gold standard, the colonoscopy, it's less than 60% of them that even get it for a multitude of reasons, right? In addition to that, you also combine it with the people that undergo colonoscopies. Although we've decreased the age from 50 to 45, we're still not having an uptake in terms of what we would ideally like to be at, which is close to 90 to 100% from a screening test. So this is one additional piece of this whole option that we have to help our patients get tested. This is the first blood test that's looking at your circulating DNA within the blood to basically detect colon cancer earlier.
So this is you're basically looking for a particular DNA because this DNA is very much or always or sometimes associated with colorectal? How does that work?
Correct. So it's basically a combination of all of that. So what we've seen in the study of almost about 10,000 patients, right, is the sensitivity is what you need in a screening test is about 80%, which is great. However, when we look at these specific precancerous lesions that go into cancer in a majority of these cases, the detection is only about 13%. Now, when you counter that with, say, a stool DNA test, right, that is about 60% detection. So although this is a good screening test, this is, like I mentioned, it's still one of the tools that we have in our toolbox. And as much as this would probably get patients who do not want to do a colonoscopy, who are those patients, right? I mean, I had my colonoscopy a few years ago. The colonoscopy I didn't even remember because I was under, right?
Right.
But the prep was the part, and all my patients, majority of them tell me, Dr. K, I'm happy to do the colonoscopy once a year, I'm fine. But the prep is what really takes it out of a lot of patients.
I would, once a year. Holy smokes, that would really be something. But again, you mentioned the polyps and the spots and things like that. How important is it to see those things? Because the colonoscopy, as you said, that's gold standard here.
That is. I mean, so that is extremely important because if you can't recognize a polyp, which is going to turn cancerous, right? And if you can only recognize it in less than 15% of the times, then it's 85% of the times that you don't recognize these precancerous lesions. So that is one of the biggest drawbacks of this study and the test itself. But as technology evolves, right, so we're looking at circulating DNA. Now we are looking at circulating RNA. We're looking at exosomes. Some of these things can actually make the sensitivity of these to be able to detect it. And the reason why these precancerous lesions aren't detected in this test is because of the fact they're not shedding that DNA into the bloodstream where it's picked up.
But are they shedding something else? Is anything else? Is there any other blood? You kind of mentioned RNA and all that.
Right.
Is that where you go for something like that?
So, but that is still in the experimental realm.
Gotcha.
And again, if we were talking about circulating tumor DNA being a test for colon cancer about 6 years ago, I would have said, yeah, that's a great goal to have, but we're definitely not there by any means. So now that with advances in technology, I'm sure we'll get there. But at this point in time, it's still a colonoscopy is still the gold standard.
So someone takes the blood test.
Right.
They take the blood test. It says, doesn't turn out all that well.
Right.
What happens then?
So then the next step would be to get a colonoscopy to confirm the diagnosis, but also to identify exactly where that lesion is and the rest of the features that you need.
If you have a colonoscopy and it's clear, all systems go, everything great, do you take the blood test instead of a follow-up colonoscopy?
So that's a great question. So the question is, if it's positive and then your colonoscopy is negative, if a blood test is positive and then your colonoscopy is negative, again, it depends if the polyps, if the polyps that are detected during that colonoscopy, then your recommendation in terms of what you would be doing would be dependent upon those polyps. not based on doing another blood test in 3 months or 6 months or 12 months.
Right. But I guess what I'm saying is if you have a colonoscopy, whatever the age might be, they usually want you back in 10 years or something along those lines.
It could be 3, 5, or 10 years.
Yeah, yeah.
Correct.
But if it's all clear and everything, if it's all clear, do you go back first with the blood test, or is it still wise to do the colonoscopy?
Correct. So this is a screening test as that first step.
Yes.
And that's what it is.
Yes. All right. So you think the FDA? What's holding up the FDA? What's the approval process?
The FDA has gotten pretty efficient in terms of approving tests and drugs. And at this point in time, they're analyzing the rest of the data and trying to come up with their recommendations in terms of what is the subset of people that they're going to actually approve this in. And that would probably take a few months, but we are hopeful that we're going to get this hear this very soon.
It's going to be a big deal when they approve that, isn't it?
It would be, because it's the first blood-based test for the screening of colon cancer, which is what is exciting.
Yes,
Yeah.
it very much is. Thanks again for sharing the information. We'll look for the FDA approval. Thanks for joining us. We appreciate it.
Thank you, Ted, for having me.